is Matt Beal. I'm a pediatric psychiatrist. I'm based in Washington, D.C. I've been in academic medicine for my whole career. I'm the chief of the division of child psychiatry at Georgetown University in D.C. And most of what I do is develop clinical partnerships with pediatric primary care and with schools around expanding access to high quality mental health services for kids. So I've done a lot of work with pediatric partners here in DC and other parts of the country too. And I joined Fort Health as the chief medical officer last summer. I'm really interested in Fort's mission and very supportive of it, which is really around democratizing access to high quality mental health care for kids through partnership with pediatrics. So I think the key to getting better care to more kids in a more timely way is going through the relationships that families trust most, which is with you and your colleagues, and providing better access to good partnership than most pediatricians have access to, unfortunately. So I'm going to share a screen and just walk through just a framework, because I think the idea tonight was to talk about anxiety. But you certainly don't need to hear a 45-minute lecture at 7 o'clock at night. So I'll frame it a little bit, and then would love just to hear general questions or specific questions. Glad to talk about cases. Glad to talk about whatever is helpful. So just a few thoughts here about recognizing and addressing anxiety in peds primary care. The why, I think, is probably very obvious. I don't need to preach to the choir, but anxiety is the most common presenting mental health problem in kids. It's also, contrary to popular belief, it doesn't tend to be a phase. It tends to be highly persistent. Anxiety in kids tends to show up and then to recur and recur and recur. And if it's untreated or unaddressed, it very often progresses to depression in early adolescence, and then to substance use in later adolescence and young adulthood. So it's really salient to try to address it earlier on. There are a lot of different options for intervention, and we'll talk about some of those, but it's not a one size fits all. And you can find interventions that work for you, your practice, your behavioral health partners, and then what kids and families want. So there's a lot of chances to be flexible. And I think of all the conditions in mental health care, it's the most fun to treat. Because it gets better, and it gets better quickly, and it gets better in a way that's really satisfying for everybody. So the role for assessment and anxiety is as important as it is in any other part of mental health care in the pediatric setting. Some of the most common assessment tools that are used are usually divided by developmental stage. So from sort of 4 to 11 or so, the SCARED is the most common sort of distributed tool, and it's a really good clinically useful tool that's well written, well validated for kids that are 12 and up. The GAD-7 is what most practices use. It's even shorter than the SCARED, and again is really user friendly. Many practices use either the pediatric symptom checklist or the strengths and difficulties questionnaire, which are not just for anxiety, of course. Those are for anxiety, depression, trauma, sleep problems, disruptive behavior problems, attention problems, a full spectrum. But both of those tools are really great for getting a global assessment and sort of thinking in terms of buckets of problems. That tends to be very user-friendly in primary care. And then for anxiety in particular, your history and your knowledge of the family is the most useful assessment tool. Pediatricians most often have their sort of intuition at play around anxiety and can tell when kids are struggling and when things aren't developing the way that they should, particularly when you've known kids since they were babies. The way anxiety shows up developmentally differs across age group. So in preschool age kids, you'll usually hear from parents about problems with separation, problems with sleep, and problems socializing at preschool or childcare. Those are usually the presenting complaints that turn into an anxiety concern. For elementary school age kids, a lot of somatic symptoms, the kids that are showing up with headaches and stomach aches again and again. Kids who parents tell you are reluctant to try new things. They won't go to swimming classes. They won't go to soccer practice. They won't try piano. They won't go to birthday parties. They won't do things that are new. They feel overwhelmed by that. Oftentimes, it shows up as anger or irritability as the presenting problem the parents are struggling with. Kids who worry about everyday challenges, about school, about friends, and then again, sleep problems are very common. And then by sort of tweens and early adolescence, it's more often panic attacks, social anxiety, performance anxiety, and then worries about school and worries about the future. So I'm sure these are very, very common things that you hear about in your practice every single day. The first three questions that the PCPs that I work with, I think, are best served to think of is, as soon as this is on your radar, which oftentimes is 30 seconds into a visit, is what's the level of impairment? Is this kid a kid who's anxious but functioning just fine? Or is a kid who's anxious whose life is really shutting down as a result? So is the impairment kind of low, medium, or high? The second is trauma. This can be a presenting symptom of trauma. So if something happened in this kid's life that either that the parents know about, so a loss, a death in the family, some sort of disturbing thing happening to a loved one or in the home, or something that the parents may not know about, but this may be the first sort of indication that something may have happened to the kid that the parents don't know about. And so it's certainly worth doing a bit of investigation about potential trauma that just takes a couple questions with parent and child. And then finally, and this is sort of a big focus of my work, is family factors. So parents' own anxiety, and then parenting behaviors in response to seeing anxiety in their kids are huge factors that determine both prognosis as well as what you ought to do in helping the family to address the challenge. So first line therapeutic interventions, and these are things that you can do in that first visit, in a 15 or 20 minute visit where this is the thing that you're talking about. First is education about anxiety, and sort of how anxiety is normal, part of being human. All kids feel it, all people feel it. Sometimes it gets to be too strong. A little bit of anxiety is good and helps us to survive and avert danger. And lots of anxiety about things that aren't actually dangerous starts to be a problem. So it's sort of normalizing and helping kids understand that this is their nervous system on overdrive, and helping them to understand that it's a problem and they need help with it, but it's also something that happens to lots of people. So recognizing that talking about it and even functioning in the world as a kid with anxiety takes a lot of bravery, and really defining bravery for kids as when something is difficult and you do it anyway, that's bravery. And they do a lot of things that are brave, and the goal of addressing anxiety is to help them be braver and braver in their lives. Sharing resources at that first visit. So I've got a couple of books that I really like to share, typically with families. I really like the book Freeing Your Child from Anxiety by Tamar Chansky, who's in Philly. And then the book by Eli Leibovitz, who's a researcher from Yale, that's called, hang on, I got the title for it. It's called, remember this one, Breaking Free of Child Anxiety and OCD by Eli Leibovitz. That's a terrific book as well that talks a lot about parents. So then finally, the first step in that, and the last step in that first intervention is, what are the child's goals? What would the kid like to do? What would life be like if they didn't feel this anxious? What would they be able to do that they can't do now? Whether it's going on a sleepover, going away to camp, or playing soccer, or being able to go to birthday parties, things that right now their anxiety is preventing them from doing, helping them to imagine what it would be like if they could do those things, and then starting to build some goals. So parenting anxiety is huge. Parents unintentionally reinforce and worsen their kids' anxiety all the time from a place of love. So there's sort of two ends of the spectrum, and this is talked about a lot in that Leibovitz book. One end of the spectrum is accommodation. And this is parents who are so bothered by seeing their child in distress that they are constantly rescuing their kid from situations that are causing anxiety in the child. And what that does unintentionally is it reinforces in the child's mind that there actually is something to be anxious about, that they need to be rescued, and they don't learn mastery. And so helping parents to recognize when they're engaging in accommodating behaviors that are making things worse, and how they can stop doing that. It's a really, really useful avenue for intervention to help kids to establish more mastery and confidence. This typically is what you see in in parents who are very anxious themselves. And so when they see their kids in distress, their own anxiety gets ramped up, and they sort of dive in and try to fix things or save their child, and it really causes problems. At the other end of the spectrum are parents who are really annoyed by their kids' anxiety, and they end up invalidating their kids' feelings. So these are parents, when they see their kids anxious or distressed, say, come on, grow up, be a big boy, be a big girl. There's nothing really to be worried about. What's the big deal? You've done this 100 times before. Your brother does it, your sister does it, your friend Tommy does it. Why can't you do it? And that sort of invalidating reaction is for kids, unfortunately, really strengthens the anxiety reaction as well, and also makes them feel really alone. So parents have to be able to recognize distress, and all that is teaching parents how to say, I can see you seem really upset, or I can see you're anxious, or tell me what you're feeling right now, help me understand. And just recognizing the kids' feelings as real, not saying that they should feel that way and not rescuing from it, but just recognizing that the feelings are real. They don't have to fix it, they just have to recognize it. So it's really helpful in a first or second conversation to ask parents about their own experiences of anxiety. Did they have anxiety as kids? Do they have it now? How do they deal with it? And this oftentimes leads pretty directly into talking to parents about getting their own mental health care, which sometimes is the very best thing they can do to help their kid. So there's some brief things that you can do in initial office visits or in follow-up visits at subsequent well-child visits when you know that anxiety is on the table. So again, what are the child's goals? What would they like to change? What would life be like without this anxiety? Addressing the parenting behaviors through talking about either accommodation or invalidation and helping the parents to identify those behaviors. I mentioned this before, but reframing the challenge the kid faces. It's less about anxiety and fear and more about bravery and courage. Brainstorm with the child and the family about exposure activities. The key to effective treatment for anxiety, absent medication, is exposure. Is basically exposing yourself to the thing that's making you anxious, surviving it, making your way through it, and building confidence and mastery from surviving it, and then doing it again and doing it again and doing it again. And so working with families to understand what's the activity that you want to achieve, what's a way to expose yourself to the difficulty and the anxiety around it, and make a plan to persist to master that thing. So, if a kid is very anxious about starting at a new school in the fall, maybe this summer they're going to the playground of that school once a week and playing on the playground and getting used to the sensation of being at that campus, being at that school, and making it start to feel familiar, even though they're going to be very anxious about it at the beginning, and building up their tolerance for that thing that makes them feel anxious. I'm sure we'll talk about meds. I think that the times to think about using medications in primary care for anxiety is severity, when the anxiety is really impacting and impairing the kid's life. When the kid's been to see a competent, solid therapist and the child hasn't responded to therapy. When the family is saying, look, we really want to try meds. It really worked for older sister. It really worked for mom. We really think it's going to work for him too. We'd really like you to try it. That's a reasonable reason. And then if you happen to practice in a place where therapy is unavailable, that's not the case in New Jersey, because you can refer to Fort Health, as we'll talk about, but it probably is oftentimes the case in many places in the country. So meds for anxiety, the effect size for SSRIs for pediatric anxiety is really good. 0.6 to 0.7 is a medium to medium large effect size. It's a really pretty robust response that you see when SSRIs are appropriately prescribed for anxiety. You see the most issues with tolerability in kids younger than 8. And once kids are 8 or 9 years old, they tend to tolerate these pretty well. A typical course of treatment should be 6 to 12 months, and then kids should have a chance to come off the meds. These should not be multi-year prescriptions. They should get a treatment for 6 to 12 months, which represents a natural course of an episode of anxiety, and then taper off the medication and see whether they can get by without it. And I put some starting doses up here for FDA-approved meds for anxiety in kids. Fluoxetine typically start at 10 milligrams, sertraline at 25, escitalopram at 5. There's some variability there, but those are typical starting doses for kids anywhere from 8 to 18. I think those are doses that I typically start at. It's important to set expectations around medications with kids and their parents. Parents usually notice the positive effects of medicine on anxiety before the kids do. Parents will notice the kids are less irritable, they're rolling with the punches better, they're more willing to try new things before the kids notice that they're feeling much different. Oftentimes parents are noticing at 2 weeks, and with kids, they're not noticing until 6 or 8 weeks that things are starting to change. The things to watch out for in terms of side effects, changes in sleep, activation symptoms. So activation is where kids are sort of hyped up, revved up. They seem kind of almost a little bit like they're manic. And of course, we do worry about in families where there's a history of bipolar disorder that these meds can precipitate mania. That's a rare but real side effect. And activation could be an indication that may be happening. So kids who the parents are telling you that they don't need to sleep, they're full of energy, they're kind of tearing around the house, they feel hyped up, like they're over caffeinated. And in those kids, you want to get them off of the medicines immediately. It's a rare effect, but it's something to watch out for. Irritability is more common, particularly in the younger kids. And then in adolescents and young adults, sexual side effects do happen with SSRIs, less often than in adults, but they definitely happen. So that's the end of the talking part. I'd love to just have a discussion, questions or reactions to any of those themes, or sort of talking about sort of themes in your practice, challenges, or specific clinical scenarios.
Thank you, Matt. That was awesome. I just want to take 30 seconds and again, just remind our group here that this is something you did out of the goodness of your heart. So that primer was perfect. And I honestly, I just did a consult today on anxiety, and I was like, oh, I could have used that. I could have, so that was you digested that to a perfect amount. So that was great. I'm really excited about the idea of the partnership here. And so I want to, just take 30 seconds and just remind or let everybody on the call know from Consensus. Dan was able to set up a automatic link now with our EMR. So if you guys have a kid who you see for anxiety and you feel that Fort Health is a good use of resources, which I think it's a fantastic use of resources, you can go and click the mental health referral button. And then in that, you can search out Fort Health. And when you do and sign the order, a fax will go right to Fort Health with all of our patients' information in lieu of the patient making the phone call themselves. And so then someone, and what Shay Stoll said, usually within a few days, they're going to get a phone call back from Fort Health, and we can establish a therapeutic alliance. And once we've established that therapeutic alliance, things can happen. And what we would love to do, and as we move forward with this partnership, is be able to avail ourselves of your therapists, and when need be, upgrade to the psychiatrist.
Right.
But I would love for you then to be able to pass it back to us,
right,
and let us manage these kids, because we need you for the consults and we need you for so this is what I see the future of this relationship. So thank you. So thank you. This was perfect tonight. Thank you.
Sure. Yeah, no, what you described is exactly what we hope for. I mean, we've got just so that your colleagues know, we've got a team now in New Jersey of about 15 clinicians. We've got therapists who are well-trained in evidence-based therapies for kids, who are available, and we'll see, as you said, Chris, get a call back from our scheduling team, typically within 24 to 48 hours. We're getting kids scheduled within a week, and getting launched into therapy. And then we've got 3 psychiatrists, and the optimal role for those psychiatrists is just what you articulated, Chris, which is to see kids where there's something tricky or challenging going on, to see them, to do a really high quality evaluation. Usually we do evaluation over 2 visits with our psychiatrists. If we're going to do medication or make a change, do that, get the kids on the right track. And in 3, 4, 6 months, when kids are really restabilized, get them back to primary care for management, so that we can keep our dockets open for new consultations. Because as a new psychiatrist moves to town, and if what they're doing is receiving referrals and keeping those kids, in 3 months, 6 months, they're full, and suddenly their answer machine says, we're not taking new patients. And that's just it's just an insane way to do medicine. It doesn't work. So we have to create this churn where we're taking kids in, doing consultation, making changes, getting back to primary care, and then available for reconsultation. And that bidirectional active living relationship is what we really are going for, Chris.
One small detail, sorry, is insurances. We take all commercial insurances in Jersey except TRICARE and the military services.
And when you say you have people in New Jersey, would the majority of your appointments be telemed or in person?
All telemed.
Okay.
So that's, we've got a team of folks that are licensed in New Jersey. Almost all of them are physically in New Jersey, but our model is really based on telehealth. And so it's not for, I'm not sure you're interested in your thoughts about that, but we think telehealth is the appropriate modality, and really an equivalent modality for certain kinds of mental health care. So for depression, anxiety, ADHD, trauma, grief, mild autism spectrum disorders, mild OCD, we can do a great job of treating those kids through telehealth. Kids who have bipolar disorder, kids who have severe autism, kids who have severe OCD, kids who have eating disorders, those kids should not be seen by telehealth. I don't think it's as effective, and it's not appropriate. And so those are not who we're seeing. So When those kids are in your practice and you're looking for treatment, we're glad to be a partner in helping to identify the right treatment locations and partners and IOPs and other kinds of treatment programs. But we're sort of narrowly focused on the 80% of kids who need mental health care for whom the severity is mild to moderate and the conditions are anxiety, depression, ADHD, disruptive behavior, grief, trauma, as I said.
One follow-up question I would have to that is, do you ever have concerns or difficulties with the telemed visit being influenced by the parent being in the home with the kid during the visit?
Yeah, it's a great question. I mean, I think it's an evolving practice, right? But I think we adjust the way that we do treatment based on the age of the kid. I mean, I think for kids under 12 or 13, we really want a lot of time with the parents. So we really make parents a part of the treatment. In fact, for most of our therapy treatment plans, we really sort of insist on meetings with the parents every 2 weeks. So after every 2 visits with the child, we want to have a visit with the parents. So the parents are part of the care. They know what's going on because there's so much a part of how what the kid's prognosis is going to look like. For adolescents, we try to create more distance and more privacy and more autonomy for the kid. That's of course is influenced by the home environment and how much space the kid has, and do they have their own room? Can they close a door? Do they have a parent who's trying to eavesdrop? Those are real considerations. We try to work with the adolescents and help them establish a setup so that they feel like there's some privacy and autonomy. But it's a factor that we got to talk about. It's just sort of part of treatment planning when you're working with teenagers.
Yeah. Okay. Thank you.
Yeah, sure.
I'll throw a question out for you. What do you see the role of a medicine like Strattera? It's a medicine I feel like is it really ADHD? Is it really for an anxiety? Do you ever use a medicine like Strattera?
Yeah, I use it fairly commonly. I mean, I think it's got. I'll tell you when I think about Strattera. So I think about Strattera if there's for kids for whom a stimulant is not an option. So kids who've got a cardiac comorbidity where I don't want to use a stimulant, kids who have clearly not tolerated several trials of stimulants before, they get activated they get too anxious, so they can't sleep, and they really clearly can't tolerate a stimulant, but they need treatment. Those are good candidates for Strattera. Kids who have coexisting ADHD and anxiety, because I mean, you probably know Strattera was originally developed as an anti-anxiety medication. It had sort of marginal efficacy. It can sometimes really be helpful for anxiety. And so when those things co-occur, sometimes it's a better choice than a stimulant. So that's the time to use Strattera. I think kids who have some particular difficulties around processing speed, there's some evidence, if you've got access to neuropsych testing, there's some evidence Strattera is better than stimulants around kids with processing speed deficits. I sometimes see that clinically. These days, it's really like third line, I think, for ADHD behind sort of all the stimulants and then the alpha-2 agonists. The alpha-2 agonists are typically what I go to before Strattera because sleep is so often a problem with ADHD, kids with ADHD, and using the alpha-2 agonists at night can really help with sleep quite a bit as well. I think the alpha-2 agonists work a little bit faster. Like the long lead time with Strattera, like SSRIs, it's sometimes 4, 6, 8 weeks before you're seeing a benefit. Whereas with the alpha-2s, you tend to see benefit a lot faster. That's helpful. And then the other limiting thing with Strattera is the GI side effects, particularly nausea, can really bother kids a lot. But I would say, of the kids who I treat medically for ADHD, probably 10% of them I have on Strattera. And for the kids for whom it's helpful, it can be really helpful. And for sort of young adults or adolescent young adults who need sort of round-the-clock coverage of their symptoms, that can be really helpful as well, because Strattera, if it's tolerated and is helpful, you don't have the waning effect at the end of the day like you do with stimulants. Typically dose Strattera, 1 to 1.6 mg per kg. It's really the only ADHD medicine to be dosed by weight. And that's a pretty reliable way to dose it. So it's, often, elementary school age kids may be starting it at 10 or 18 milligrams and have, college students who are on 100, 120.
Awesome. Thanks. That's a great synopsis. So the other thought I had is, again, I really wanted to use this as an introductory call to you and your team, and I didn't want to abuse your time here either, but I wanted a face for all our staff. And again, I'm just really excited to have this. It is so difficult, and you know that better than anybody, to have the resources. So I really feel like this is going to give our offices, a real, opens another door in a field that we really do need to feel comfortable. So I really love what you said. To me, the idea of partnering and collaborating, and I think this is going to be a great resource. And so I'm really appreciative of your time tonight. So I don't want to keep talking. Yeah, I'll let other people chime in, but this is fantastic.
I guess question for Chris's team. We talked about telehealth earlier. A question came up. Are there barriers in parental adoption of telehealth? Is there resistance when the topic comes up?
So I steal from when we had dinner this spring, and you guys, your therapists are trained in this. They're not just me doing telehealth during COVID and I just winged it and just tried to best. Your therapist, and this is what I say to all the patients, your therapists receive specialized training on how to perform telehealth and telemedicine. And when I use that and I say that to the families, I get like almost no pushback. And again, the second piece is your availability. Right. When I'm waiting for my therapist for 6-8 weeks to get in, and I can say, hey, I can get you a call back in 2 days and potentially in 2 weeks, that they're willing to do whatever. So I don't see a problem with it at all since I've used it.
The other thing that we're working on, which I hope is going to be really welcome for you and your colleagues, is sharing back. I talked about screening a little bit in the slides, sharing back our results of clinical progress, so you actually know what's happening with your patients. Obviously, if you send them for psychiatry and we start them on meds or change meds, send them back to you, that's going to come with information. But if you send a 10-year-old who's got really bad anxiety and isn't sleeping to get cognitive behavioral therapy with us, we want you to hear back from us about how they're doing. So, halfway through, 6 or 7 weeks into treatment, which was typically about halfway, you'll get an update. It says here's, and this is in progress, Chris. So this may not have happened with your patients yet, but we've got software now that we're starting to use that allows us to automatically send out update questionnaires to families, get the feedback, and say, okay, when your kid came in, the scared score was a 17. We're now 6 weeks in, the scared score is down to an 11. Now at 12 weeks, we're finishing therapy, and the scared score is now is a 3. So we've seen this really big change. We want that to get communicated back to the referring primary care doc, because you need a reference point. When the next time the kid's in your office for a sick visit or for the next well child, we don't want it to have been a black box. They got sent out for someone for therapy and something happened and now they're back in your office. We want to be able to, open up your chart and say, oh yeah, we saw, it looks like that therapy really helped. What were some of the things that you guys worked on? What was helpful? I think ideally it'll feed into you having just closer relationships with your kids and their families, and be able to respond to the next thing that comes up with more knowledge.
That's awesome, because that is completely non-existent right now. So that's awesome. Yeah.
Yeah, it's horrible. Like somehow we got to this point in behavioral health where it's just like we've given up any urgency about communicating back, and it doesn't drive it doesn't help with outcomes, and it just creates a sense of of mystery that's totally unnecessary.
So Dr. Chris, we have Dr. Mealy on the call, and I believe when we were first starting this conversation about beginning this relationship, she had sent an email saying that she has nothing but good things to say. So I was wondering, Dr. Mealy, since we're recording, if you'd maybe want to share some of your experiences with them for everyone else.
Yes, absolutely. In fact, I was just going to kind of try to jump in a little bit. We've been referring now to Fort Health for probably close to a year, I think. I feel like we might have been one of the first practices in New Jersey that was fortunate enough to hear about it. And I'll be perfectly honest, as I'm sure there are other people who are skeptical about the telehealth part of this. And I wasn't really sure the kids would all be receptive to it. I wasn't sure the parents would be, but first of all, was surprised that they were probably more receptive to it than I had anticipated. And the feedback we have gotten has been excellent. And the telehealth aspect of it works extremely well. I would say we probably now have referred at least a dozen patients over the year, and have been getting tremendous feedback from everyone. So I think this program works. I will tell you, when I first was finding out about it, I thought it was too good to be true. But honestly, it is just as good as it sounds, if not even better. So we have been referring, we will continue to refer. I love the collaborative element of it, for us to be involved with the management. I'm happy to answer any other more specific questions about our experience, but all good from where I stand.
Amazing. Thank you.
Awesome.
Thank you for the kind words. We're gonna sort of transcribe some and send it to our clinical team, just as a testament to the work that they're doing.
It's fantastic. Yeah.
You've been referring to us since October last year.
Okay. All right. Not quite a year. All right. Yeah.
Not quite a year, but I would say in October we started to hit our stride. You're definitely one of the first ones. We appreciate you.
Thank you.
Yeah, thanks for the feedback, and please let us know if there's situations that don't go well too, so we can learn from them and improve.
Oh, will do. Absolutely. Absolutely.
We're still very much in growth mode, but we're right now. I think I mentioned we're at about 15 clinicians now. We're going to be at 50 to 55 by the end of the calendar year. So the goal, we're really hiring about a therapist a week right now. And going to continue doing that throughout the year so that we can continue to say yes.
Okay. Great.